AETCM, the Emergency Medicine Channel. As a part of AM Rapid 2024, today I am presenting topic is subarachnoid hemorrhage. Coming to epidemiology, the 75% of traumatic subarachnoid hemorrhages are caused by ruptured aneurysm. 20% cases causes not identified. Remaining miscellaneous conditions are arteriovenous malformation, sympathomimetic drugs, and other less common causes. Image showing aneurysm of arteries in the subarachnoid space. In epidemiology, risk factors for subarachnoid hemorrhage are smoking, excessive alcohol consumption in patients with polycystic kidney disease, family history of SAH, a risk rises with increasing number of family members involved or with a family history of adult polycystic kidney disease, coarctation of aorta, Marfan syndrome, Ehlers-Danlos syndrome type 4, alpha and antitrypsin deficiency. Coming to pathophysiology, the precise pathophysiology is not known. Many factors are associated with aneurysmal development and rupture, which includes genetic predisposition, cellular aberration in vascular wall repair or remodeling, and aberration in the local blood flow. Larger aneurysm, which is more than 5 to 10 mm, are more likely to rupture than small aneurysm. Coming to clinical features, patients with SAH classically present to the emergency department with severe headache of acute onset, termed as thunderclap headache that reaches maximum intensity within seconds. Typically, the headache persists for several days but may resolve in a shorter period of time. Even if a patient is not experiencing the worst headache of their life, a headache that is different in intensity or quality from past headache should raise concern for SAH. Headaches associated with loss of consciousness, seizures, diplopia, or other neurological signs or neck rigidity or also require clinical investigation. Less frequently, patients may present with nausea and vomiting, altered mental status, photophobia, or symptoms suggestive of ischemic stroke. Approximately 20% of patients develop their symptoms while engaged in activities that cause increased blood pressure, such as exercise, sexual intercourse, or defecation. Coming to diagnosis, consider SAH and the differential diagnosis for all patients presenting with a concerning headache. SAH can be ruled out with 100% sensitivity with implementation of Ottawa subarachnoid hemorrhage rule for headache evaluation. Although inclusion criteria are stringent, SAH may be excluded in patients under 40 years of age, without neck pain or neck stiffness, without a witnessed loss of consciousness, without onset during exertion, without a thunderclap headache, and without limited neck flexion. Misdiagnosis is associated with normal mental status and smaller size of hemorrhage. Complications of misdiagnosis include repeat hemorrhage and obstructive hydrocephalus. Symptomatic improvement following analgesics does not exclude life-threatening causes of headache. Coming to differential diagnosis of subarachnoid hemorrhage, vascular pathology, drug toxicity, infection like meningitis, encephalitis, intracranial tumors, intracranial hypertension, metabolic derangement, primary headache syndrome, hypertensive disorders like posterior reversible encephalopathy syndrome, cerebral venous thrombosis, arterial dissection, ischemic stroke. All these include DD of subarachnoid hemorrhage. Coming to imaging, the initial diagnostic modality of choice when SAH is suspected is CT brain plain. In patients who are neurologically intact who presented with a thunderclap headache, a normal head CT within 6 hours of headache onset is extremely sensitive in ruling out aneurysm SAH. Sensitivity decreases to about 91% to 93% at 24 hours and continue to decline rapidly thereafter, reaching 50% at 1 week. Newer generation CT scanners are even more sensitive for detecting SAH, especially in setting of patients presenting within 6 hours of symptom onset and greater availability of timely interpretation by a neuroradiologist. image showing diffuse SAH and an interventricular bleed also. CT angiography and MRI or magnetic resonance angiography are options after a negative head CT. A negative MRI result still needs to be followed by a lumbar puncture. Coming to lumbar puncture in SAH. Advantage of lumbar puncture is the ability to identify other causes of headache, such as meningitis or idiopathic intracranial hypertension. The disadvantage of lumbar puncture include post-lumbar puncture headache and other discomfort for the patient. The lumbar puncture may be contraindicated in patients with coagulopathy or thrombocytopenia. The two CSF tests are the presence of xanthochromia and red blood cell count. Xanthochromia is a yellow appearance of CSF due to the enzymatic breakdown of blood-releasing bilirubin. The RBC count in the third or fourth tube of CSF is commonly used to identify SAH. A normal findings on CT head, the absence of xanthochromia, and zero or few RBCs in the CSF exclude SAH. A normal head CT result with a positive finding of xanthochromia or elevated RBC count in the tube 4 should be considered diagnostic for SAH. Coming to SAH grading scale, most widely used include the Hunt and Hess scale and World Federation of Neurosurgical Society scale. Coming to treatment, medical treatment should target the prevention of complication, reassess the Glasgow-Coma scale and pupillary response regularly because a decrease of one Glasgow-Coma scale point indicate the onset of complications. Intracerebral and extracerebral complications of SAH include rebleeding, vasospasm, cerebral infarction, cerebral edema, obstructive hydrocephalus, intracranial hypertension, fluid and electrolyte abnormalities, respiratory failure, myocardial dysfunction, thromboembolism, sepsis. The risk of rebleeding is greater in the first 2 to 12 hours and can be reduced by adequate blood pressure control. Control blood pressure with titratable agent to balance the risk of stroke, hypertension-related rebleeding, and maintenance of cerebral perfusion pressure. A titratable IV antihypertensive is preferred. Injection labetalol and nicardipine are often used. Avoid nitroprusside and nitroglycerin because they increase the cerebral blood flow and intracranial pressure. It also causes rebleeding. Antifibrillatics are not used because there is a risk of increased cerebral ischemia as well as other dangerous complications. Pain medication and antiemetics are used. Vasospasm complication is most common to 2 days to 3 weeks after SAH. Protective benefit is seen with administration of nimodipine. That is, we can give nimodipine 60 mg per oral every 4th hourly. And this therapy should be initiated within 96 hours of symptoms onset unless contraindicated due to allergy and non-functional GI tract or hepatic disease and continue for 21 days. Delayed cerebral ischemia is associated with hypothermia, hyperthermia, and hyperglycemia and can be prevented with appropriate use of warming or cooling blankets, antipyretics, or insulin as indicated. Disposition and follow-up. Admit all patients diagnosed with subarachnoid hemorrhage to intensive care unit in consultation with a neurosurgeon. In patients with normal finding on head CT and CSF analysis, within 2 weeks of occurrence of initial headache symptoms may be safe for discharge from ED. Consider consultation with a neurosurgeon for patients who present more than 2 weeks after a sudden onset of severe headache causing suspicion for subarachnoid hemorrhage if the initial workup yield normal finding. Thank you.